So today's topic is migraine, and I'll be speaking about the various aspects of migraine, how to manage migraine. It will be basically be a practical oriented talk. So we'll not go into much theory. We'll be basically I'll be telling you how to approach patients with headache and also with migraine. Okay. So I will be speaking on approach to headache. Then what is the migraine epidemiology, pathophysiology, the various types of migraine, what are the various other primary headaches, what is the treatment of migraine, and medication overuse headache I'll be speaking about, and also special situations like pediatric population and also pregnancy. So before going into the topic, I think we should have a basic idea of how do we classify headache disorders. So headache disorder is classified as a primary headache, secondary headache, and then cranial neuralgias. So what is primary headache? Primary headache means headache due to a underlying due to a primary headache disorder without any underlying structural cause in the brain. So there is no lesion in the brain, there is no structural lesion in the brain which is causing the headache. It's a primary headache disorder. So the most common primary headache disorder is migraine, followed by tension headache, and the third most common headache disorder is cluster headache and trigeminal autonomic cephalgias. There are other primary headache also which are rare, and I will be speaking about them also. So when you speak about primary headache, you think of three disorders: migraine, tension headache, and cluster headache, and other trigeminal autonomic cephalgia. So these are the three common types of primary headache. Coming to secondary headache are all the other causes of headache which we know about. For example, if you think of traumatic brain injury, so if there is traumatic brain injury, the post-traumatic headache, it's a secondary type of headache. Suppose there is a cranial or cervical arterial dissection, carotid artery dissection, cervical arterial dissection, or a vertebral artery dissection, and then there is headache related to that. So that is a secondary headache. Other non-vascular intracranial disorders, for example, a brain tumor, a stroke, or any other pathology inside the brain giving rise to headache. So that is a secondary headache. Substance abuse, alcohol withdrawal. So we know that after taking alcohol, next day morning there can be headache. So that is alcohol withdrawal headache. Again, other drug-induced headaches can occur. So all these are secondary headaches. Infection of the brain. Suppose we are having a meningitis, a encephalitis, or any other chronic infection of the brain which is giving rise to the headache. So that is a secondary headache. Any infection of the nose, sinuses. We know that sinusitis can cause headache. Teeth ache, especially the upper tooth, can cause headache in the maxillary area, and which can radiate upwards also. So teeth, nose, sinuses, eyes, for example, glaucoma or uveitis, RITs, all this can cause a headache around the periorbital area. So this causing headache is again cause of secondary headache. Then headache due to psychiatric disorders, for example, psychosis, and patients with depression, anxiety, and all can have psychogenic headache. So that is again a secondary type of headache. So these are the various secondary causes of headache. And third group is the cranial neuralgia. So most common cranial neuralgia which we know about is trigeminal neuralgia. So trigeminal neuralgia, other atypical facial pain syndromes. So these are grouped into the third group, that is called as cranial neuralgic group. Now, as I told, there are other primary headache. So what are the other primary headaches? So other primary headache is primary stabbing headache, in which you get stab like pain. You must have seen patients who come and say that there is a stabbing or knife like pain in a small area of the brain, and it lasts for seconds and goes off. So that is a primary stabbing headache. There is a cuff headache. So patient cuffs and then develops headache. So that is a primary cuff headache. Exertional, after exertion there is headache. So that is primary exertional headache. There is something called as coital headache, which occurs after coitus. So that is coital headache. Hypnic headache, primary thunderclap headache, and daily persistent headache, new onset daily persistent headache. So all these are primary headaches in which there is no underlying CNS cause, but this occurs in specific situations like cough, during exertion, during coitus, and other conditions like primary stabbing headache. Now you have to remember that in all this group of headache, you have to rule out a secondary structural cause. That means you have to do the scan of the brain and then rule out a secondary cause in the brain which is causing headache. For example, primary cough headache could be a feature of subarachnoid bleed. Cough headache could be a feature of Arnold-Chiari malformation in the in the posterior fossa. So that may cause cuff headache. So it is a very common manifestation of Arnold Chiari malformation in which patient can present with cuff headache and cuff syncope. So these primary headaches are diagnosis of exclusion. So you have to do the scan, and suppose a patient develops headache during coitus. Again, the first differential diagnosis is subarachnoid hemorrhage. So you have to rule that out to say that this is a primary headache. Unlike migraine, in which there is no need of doing the MRI scan if the patient is fitting into the criteria. So that is the difference between migraine and these primary headaches, in which you have to rule out the secondary causes by doing a scan of the brain. So after going into the classification, so we must always remember that the most important investigation in a patient with headache is the history of the patient. So history will give us the clue regarding the diagnosis. It's not the MRI scan, it's not the CT scan or any other investigation. It is the history and history only. So in these patients, whenever a patient comes with headache, you have to ask history of the onset of the headache. So onset is very important because, for example, if it's a migraine, it's a gradual onset headache and which increases and reaches the peak in 30 to 60 minutes. If it's a cluster headache, then the onset is very abrupt. So it increases and reaches the peak within 15 to 20 minutes and stays there for 2 to 3 hours and then gradually comes down. So that is cluster headache. If it is a thunderclap headache means a headache which reaches the peak within 1 minute. So the headache starts and then it reaches the maximum intensity in 1 minute. So that is thunderclap headache. So if you get a thunderclap headache, you know that this is something serious like a subarachnoid hemorrhage or cerebral venous thrombosis or pituitary apoplexy or in a dissection or something like that. So the onset of the headache is a very important thing. Second is the temporal profile. So temporal profile means once the headache has occurred, what happened to the headache? Was it increasing? Was it gradually reducing? How long does it last? Whether it was relapsing and remitting? So this course will tell us regarding the etiology of the headache. For example, a migraine headache will be gradually in onset, will reach the peak in 1 to 2 hours, and it will be there for almost 4 hours to 72 hours. 2 to 3 days it will be there and then it will subside. So the duration of migraine is 4 to 72 hours. While if it's a cluster headache, the duration will last for up to 30 minutes, will start from 30 minutes to 3 hours. So that is the duration of cluster headache. So that will give the etiology of the headache. Somebody's microphone is on. Can you just mute yourself? Yeah. So if it is a location, so if it is a migrainous headache, it's a unilateral headache, throbbing pain, usually temporal or parieto-occipital in location. So that is a migrainous type of headache. Though migrainous headache can occur in any side, that I will be telling later on. If it's a cluster headache, it will be periorbital headache around the eyes and this area. So that is cluster headache. If it's a tension headache, it will be a band-like sensation around the head. So it will be a hollow cranial band-like sensation. So the location of the headache will also give us the etiology. If it is a low CSF headache, for example, what occurs in a lumbar puncture, after the lumbar puncture, the patient develops a headache. So that will be posterior and towards the neck. So the headache will, the location of the headache will give us a clue regarding the etiology. The time of the day, again, it is very important. Tension headache or stress headache occurs towards the evening hour after work, and then they develop the headache. If the headache occurs in the morning hours, so that is early morning headache with vomiting is suggestive of raised intracranial pressure. If the headache occurs in the afternoon period and then increases on bending down with sinus symptoms, so that is suggestive of a frontal sinusitis. Now, quality of the pain is also important. The most important thing which you will ask the patient is whether it's a throbbing or non-throbbing. So if it's a throbbing pain, it is likely to be migrainous in etiology, while non-throbbing pains could be of other etiology. Now, if it's a explosive pain, so that could be suggestive of a cluster headache in which the pain is severe and explosive in nature. Now, aggravating and relieving factors are also very important. For example, if it's a migrainous pain, it will be increased on going to the sunlight, on taking, on doing work, on talking, on climbing stairs, doing activities, while it will be reducing on lying down and switching off the light in a dark room when the patient lies down improves. Suppose it's a case of headache, the headache will be increasing on sitting down and on lying down it will reduce. a raised ICP headache, it will be increased on lying down and reduced on sitting. So this change in the posture and the headache will tell us regarding the cause of the headache. I think coming to the drug history is very important because many of the drugs can give rise to headache. For example, if you take nitroglycerin, calcium channel blockers, these are all vasodilators and this can give rise to headache. So whenever a patient comes with headache and if there are multiple medications, you have to see whether it's a drug induced or there is some drug which is causing the headache. For example, cardiac patients will be on nitrates. So that is a very common cause of triggering the headache. Now coming to systemic illness, very important. Any patient with headache, you should ask the systemic history. For example, if the patient is diabetic, if the patient is immunosuppressed, what all risk factors the patient is having, whether the patient is having a history of fever, night sweat, it could be tuberculous meningitis, it could be a diabetic infection, intracranial infection, or it could be some opportunistic infection in HIV patients. So that history is very, very important to get the systemic illness. Now, this is a mnemonic which I would like to share, which will tell us that the headache is due to a secondary cause or there is some severe, serious underlying pathology in the brain. For example, if there is systemic symptoms, so S stands for systemic symptoms. So if there is fever, weight loss, diabetes, HIV history, you have to be very careful. One important thing is I'd like to share is systemic malignancy. If there is any history of malignancy and the patient develops headache, you should be extra cautious in these patients because it could be a metastasis of the brain. It could be either a CNS spread, so in which you will not get seizure, you will not get any focal neurological deficit. It could be a spread through the CSF. So that also has to be kept into mind. Abnormal neurological finding. So whenever a patient has headache, and there is some focal neurological deficit like a hemiplegia, hemiparesis, some ataxia, some facial deviation, cranial nerve involvement, papilledema. Again, you have to be very, very alert in these patients. Onset, if there is a sudden onset, an abrupt and split second onset. So that means thunderclap headache. So if the headache reaches its peak within 1 minute, you have to be very careful. So this is likely to be a subarachnoid bleed, pituitary apoplexy, CVT, intracranial hypotension, dissection. All this can give rise to a thunderclap headache. So that is a red flag sign. Older patient, any older patient more than 50 years without past history of headache, developing sudden onset headache, you have to be very careful. And there is one condition which can occur in older patient, in which you can have elderly patient complaining of severe pain and there will be swollen blood vessels and temporal artery tenderness, scalp tenderness. There may be jaw claudication. So they say that while chewing the food, they develop claudication of the jaws or the tongue. They will be having polymyalgia rheumatica. So they will be having difficulty in lifting the arms or getting up from floor. And they may be having fever, anemia, raised TSR, raised CRP, and then jaw claudication, and then scalp tenderness. Elderly patient. So this patient, again, you have to be cautious because this could be a case of temporal arthritis. Why is it important to know this condition? Previous headache history is very important. Suppose a patient has long history of headache, years of headache, long history, on and off, relapsing remitting course. So that means you know that it's a primary headache disorder like a migraine. So you need not worry much. A recent onset, sudden onset of headache, recent worsening headache over the past 2 to 3 months is the dangerous type of headache which you have to be very careful about. For diagnosis of migraine, at least there should be 5 attacks of headache. So if you are having a 5 attack of similar headache which is occurring and then relapsing and then remitting on its own and the patient is absolutely normal in between, you can safely diagnose migraine. So that is the importance of history. You have to take the past history of headache and the entire duration of the headache, what is the frequency of the attack, what is the duration of the attack, what is the triggering factor, what is the relieving factor, whether there is nausea, vomiting, photophonophobia, everything has to be taken in the headache history. So these 6 things, if you remember, 5 things, if you remember, that is Snoop, you can definitely rule out any secondary or serious causes of headache. Now, after taking the history, once you are sure that this is a type of primary headache and you diagnose migraine, so what is the confusion with migraine? As we all know, migraine is one of the most frequently misdiagnosed condition and also underdiagnosed and undertreated condition. A patient with migraine in the community, most of them feel that it is due to eye problem. So most of them will go to the ophthalmologist for an eye checkup. Many glasses will be changed. Somebody will be saying that you are having eye issues. So the refractory error, that is why you are having headache. then the glasses will be changed once or twice, and then still the headache persists, and then they will meet the ophthalmologist. Then they will say that you are having something else, go and meet the physician or neurologist, and then the patient is diagnosed with migraine. So this is one scenario. Some of the people may be thinking that they are having gas, because most of the migraine patient will have prodromal symptom of acidity, bloating, and all those things. So this will be taken as the gas triggering the migraine. So this is a common assumption that it is the gas which is causing the migraine. Some patients will think that it is due to sinus. So any headache around the eyes and this area, that is cheek, they think that it is due to migraine. So sinusitis is due to sinusitis. So sinusitis is one again common misdiagnosis. Then cervical spondylosis. Few of them will be saying that there is some neck pain. So neck pain, and which is going upwards towards the scalp. So people will think that it is likely to be due to cervical spondylosis. So these are the common misdiagnoses which may be there. So sinusitis, cervical spondylosis, gastritis, and then refractory errors. And some people may be having unnecessary fear of tumor. So they will be thinking that any headache is tumor. So they will be very scared about that they're having a tumor. Sometimes patient is having headache, and then most of the time when the CT scan is done, they find that the CT is normal. So everybody is puzzled what the cause is. So the general awareness about migraine is very low, and sometimes there may be a calcified nodule in the scan, like in this patient, and the calcified nodule may be attributed that this is giving rise to the headache. So these are the various situations which can occur. Sinus surgeries may be performed in migraine patients thinking that the migraine is the headache is due to sinusitis. So this is the common scenario which we see in clinical practice. Migraine is one of the most common condition. Almost the community prevalence is 13 to 15%. So you can see how common it is. It is a very common disorder, and it is thrice as common in females as compared to male. So male it is around 6%, female it is around 18%, and 50% of the cases are underdiagnosed, and almost 50% are undertreated. So it's a highly underdiagnosed condition and undertreated condition. You will be amazed when you ask people in your OPD regarding the history of migraine, and you can see that many of the people are having migraine, and they have considered it that they are having some gastritis, or it is due to some sinusitis and all. So most of the people who say that I am having a history of sinus headache is actually migraine. So this is the 2018 Lancet paper, which shows that after low back pain, migraine is the second most common disorder which causes disability, and the prevalence is around 14.7%. So it's a very, very common disorder, similar to iron deficiency anemia, then tapeworm infection, caries. So similar is the prevalence of migraine. So it's very, very common disorder, and I think every doctor should be quite aware about the treatment and evaluation of this. A vascular pathology. So that means it was called as a vascular headache. So that's why it was called as vascular headache. It was thought due to vasodilation in the blood vessel. But later on, we find that vascular is just a minor part of the pathophysiology, and there are many other complex mechanisms which are involved in it. So usually there is a genetic predisposition. Most of the migraineurs will have a family history, and there will be some genetic or environmental predisposition. They will be having a hyper excitable brain. So there will be a cortical hyperexcitability, and there will be a dysfunction of the hypothalamic neurons, and also brainstem dysfunction, which is giving rise to the premonitory symptoms. So what are the premonitory symptoms? Premonitory symptom is that sometimes we see that before 1 to 2 days or few hours of the migraine attack, most of the patient will have some hypersomnolence, yawning, some tiredness. Some patients will be having food craving. So all these things are premonitory symptoms which are due to the hypothalamic involvement in the premonitory phase. And after that, there will be the cortical spreading depression. So this is the electrical activity in the occipital part of the brain, which is called as a cortical spreading depression, which starts in the occipital lobe and gradually progresses towards the anteriorly, towards the parietal lobe. And the progression is around 1 to 3 millimeter per second. And this will be very gradually progressing. And this electrical phenomena is giving rise to the aura in the migraine. So few patients will have aura. So this electrical phenomena is the cause of the aura. And once the electrical activity spreads anteriorly, it will involve the trigeminal vascular system. So you are having the blood vessels and the trigeminal nerve and its branches around the blood vessel. So this system is involved, and because of that, there will be vasodilatation of the blood vessels, and also there will be a sterile inflammation inside the blood vessel and the meninges, and which gives rise to release of lot of peptides like substance P. There is CGRP, that is the calcitonin gene related peptide, which is the main molecule behind the migraine, and all of this will cause excitation of the trigeminal nucleus. So we know that the trigeminal nucleus is a very long nucleus which starts from the around the pons and it goes up to the C2 level. So whole of the trigeminal nucleus will be involved, and from that there are connections to the back to the thalamus and from the cortex, and this loop goes on from the cortex, thalamus, trigeminal nucleus, and this loop goes on, which gives rise to the peripheral and the central sensitization. So involvement of the trigeminal branches will give rise to the peripheral sensitization, and then thalamus and the cortical structures will give rise to the central sensitization. So the electrical phenomena involving the occipital lobe gets converted into a vascular phenomena, which gets converted into a chemical phenomena. So electrical, vascular, and chemical. So all these things give rise to the various manifestations and involvement of the migraine. And this sensitization which occurs, the complex vicious cycle of connections between the trigeminal nerve, thalamus, and the cortex gives rise to the whole sensitization and the chronicity of the illness which occurs later on. So this again shows this pathophysiology. You are having the cortical hyperreactibility, and the migraine vein is hyperexcitable, and there are a lot of triggers which give rise to the premonitory symptom. You can see this is the functional MRI, and you can see the various areas which are getting involved. The hypothalamus and all those areas are involved in the premonitory area, and this is the cortical spreading depression which occurs in the occipital portion, and that gives rise to the various vascular dilatation, vasodilatation, and the sterile inflammation, and the migraine and the various manifestations of the migraine. So this is the key molecule which gives rise to migraine, CGRP, that is calcitonin gene related peptide, which causes vasodilatation, dural inflammation, peripheral sensitization, and the pain transmission. So this is the key molecule, and most of the treatment, newer treatment, monoclonal antibodies, etc., are against this CGRP molecule. Now coming to the migraine proper, how do you classify migraine? So ICD 2018, ICD-3 has classified migraine into the following types. So there is migraine without aura or the common migraine. There is migraine with aura. So aura, I'll explain what an aura is. So migraine with aura is there, in which you are having the migraine with typical aura, which is the visual aura, and then you are having brainstem aura, hemiplegic migraine, retinal migraine, various other types are there. Then there is something called as chronic migraine, in which you are having a continuous headache for at least 15 days per month for 3 months together. So that is chronic migraine. And then you can have complications of migraine. Most of you must be aware that migraine can give rise to stroke as well. Especially female patients, smokers using oral contraceptive pills, etc., can develop stroke along with migraine. So that is migrainous infarction. They can go into a status epilepticus, you must have heard, in which epilepsy, if the seizure continues more than 30 minutes, we call it status epilepticus, or if 2 seizures occur without gain of consciousness, it is called a status epilepticus. So similarly, in status migrainosus, if there is continuous headache more than 3 days, so it's called a status migrainosus. So that is one other complication. And sometimes migraine aura triggered seizure. Sometimes the aura can trigger a seizure as well. So that is again one complication. And then there are probable migraine syndrome, in which the criteria is not fit, but few of the manifestations may occur. And episodic syndromes, which may be migraine equivalents, which occur in the pediatric age group, is another group. So this is how migraine is getting classified. Now, what is the diagnostic criteria of migraine? So common migraine, that is migraine without headache, the diagnostic criteria is at least 5 attacks should be there. Each attack should last from 4 to 72 hours. And the headache should have 2 of the 4 characteristics. So it should be unilateral, it should be pulsatile, and it should be moderate to severe intensity. It is very important. So unlike tension headache, in which the patient is having headache but is able to do most of the activities, migraine patient will have a moderate intensity. So they will not be able to function in a normal way during the attack. So that is a very important differentiating point, which helps us to differentiate from tension type of headache. So it will be moderate to severe, and there will be aggravation on physical activity. So they will be, while they are walking, doing physical exertion, the headache will be increasing. So you need 2 of this 4. and the headache should have nausea or vomiting or photophonophobia. Either one is enough. So there may be nausea feeling or photo or phonophobia. Either one is enough, and it should not be accounted by any other illness. So this is the diagnostic criteria of migraine. Now, so if the patient comes with first attack of headache, you cannot diagnose migraine. There should be at least 5 attacks fitting into this criteria to diagnose or classify as migraine. Now, what is migraine with aura? So migraine with aura means there are the features of migraine with the aura. So what is a aura? Aura means a complete reversible focal neurological symptom which has a slow march, which is a mix of positive and negative symptoms. Now, this slow march is very important because aura can occur in epilepsy also. We know that auras occur in epilepsy, but the migraine aura will be slow. So it will be 5 minutes to 60 minutes. It will start gradually and it will progress gradually and will go off within 60 minutes. So it will last less than 60 minutes. So that is the differentiation. And sometimes the aura will precede the headache. The aura may be prolonged and there will be mild headache. Sometimes there may be headache and then there will be aura and then headache later on. And rarely there may be just a aura without any headache. So these are the various type of associations which can be occurring. Now the most common aura is visual aura. So how will you differentiate a visual aura from an epileptic aura? Now in an epileptic aura, this is a classical explanation of epileptic aura. Usually you will get colorful pictures, colorful patterns which will be seen, geometric patterns which will be seen in an epileptic aura. While in a migraine aura, you can see this. So there will be a, it will be usually be black and white. It will start from one end of the field and will be gradually expanding. So you can see it's expanding here and it is expanding here. So it will start from one end. It will be small. It will be zigzag lines. It will be black and white and it will gradually expand and progress towards the visual field. This progression will be in a duration from 5 minutes to 60 minutes. While an epileptic aura will be sudden onset, you will get colorful geometric pictures, geometric lights, and it will last for minutes. So it will not be very prolonged and it may end up in a seizure later on, or the aura may subside on its own. So these are the very important things, because sometime in children, like in occipital lobe epilepsy and all, there may be visual aura and then there will be minor seizure which may be missed, and there will be postictal headache also. So it can be a important differential diagnosis of migraine with aura, that is occipital lobe epilepsy. So with this duration of the attack and the progression of the aura, you can definitely differentiate whether it's an epileptic attack, epileptic aura, or a migraine aura. So there is something called as basilar migraine also. This is again a complicated migraine in which you will have a migraine criteria, and along with that there should be 2 of these features. So that is dysarthria, vertigo, diplopia, etc. So you think that you should understand the basilar circulation. So the basilar artery is supplying the cerebellum and the posterior, the brainstem and the structure. So if the cerebellum is involved, the blood supply to cerebellum, so then you will get ataxia. If the brainstem is involved, you will get. Kindly mute your mic, please. Kindly mute your mic, please. So you will have a diplopia, dysarthria, dysphagia, and the dizziness, and along with ataxia, and the headache will be occurring. So that is a basilar migraine, and it will be reversing in some time. Now, other thing is vestibular involvement. মাইকটা অল্প এ করে নেন, মাইকটা মিউট করে দেন। Okay, so what is vestibular migraine? So we have heard people with migraine having some dizziness. So if you look at the dizziness, most common cause of dizziness is benign positional paroxysmal vertigo, in which you'll have a positional dizziness on turning in the, rolling in the bed, getting up, or looking up or looking down, you get dizziness. So that is BPPV. The second most common cause of dizziness is vestibular migraine. So vestibular migraine means you'll have all the migraine feature, and along with that they will be having dizziness. So that is vestibular migraine. So here you should have at least 5 episodes, and each episode will be lasting from 5 minutes to 72 hours. And you have to remember that the dizziness in vestibular migraine may be acute, it may be chronic dizziness, it may last for minutes, it may be positional, it may be non-positional also. So all type of vertigo can occur with vestibular migraine. So if there is a history of headache and there is dizziness, then definitely you have to rule out vestibular migraine. The rest of the characteristic of the diagnostic criteria is same. Almost 50% of the migraine attack should have some vestibular dizziness and vertigo-like feeling to call it as a vestibular migraine. So it's again a very common cause of dizziness. Now coming to the phases of migraine. So as I already told, there is a prodromal phase because of the involvement of the hypothalamus. There can be yawning, depression, lethargy, craving of foods, etc. Second stage is the aura stage. If it's a migraine with aura, you will get the aura of flashing lights, zigzag lines. There may be some sensory aura in which you can have tingling in the limbs. There may be speech difficulty during the aura. So all those things can occur in an aura. Then third is the headache, in which we are having the criteria of headache, 4 to 72 hours, throbbing pain, pulsatile pain with photophonophobia, nausea, increasing on exertion and activities. And later on, there is a post-dromal stage. So like the pre-drom, there will be a post-drom in which the migraine patient will have depression, fatigue, and all those things, which will last for 1 to 2 days. So you have to think that apart from the 4 to 72 hours of the headache, there is 1 or 2 days of pre-drom and there is a 1 or 2 days of post-drom. So the disability of the patient may last up to 4 to 5 days, which will include the headache per se and the pre-dromal and the post-dromal phase as well. So that also accounts to the disability. So the treatment of migraine is important because with the treatment you can prevent the post-dromal symptoms as well as the pre-dromal symptoms, which also give rise to the disability and affect the quality of the life. Now always remember, we have given the diagnostic criteria and all, but textbook cases are not seen and the patient do not read the textbook. So despite we say that it's a unilateral throbbing headache, the headache may be central, the headache may be in the vertex, headache may be around the neck, around the eyes, etc. That is because of the wide distribution of the trigeminal nerve. So you know that the trigeminal nucleus spreads right from the brainstem up to the C2 spine. And there are a lot of connections to all the parts of the skull and the scalp and the neck also. So the pain of the migraine can get dispersed to various areas. So the location of the headache may vary in various patients. Most important thing is the triggers. If the headache is triggered by certain thing like going to the sunlight, taking particular food, on fasting, on various smell, on eating some spicy food and all those things. So that means there's a triggering factor. So if there is a definite triggering factor, it is likely to be a migraine. If there is a positive family history, it's likely to be a migraine. If there is accompaniments, that means if there is nausea, vomiting and other symptoms, then it is likely to be migraine. If there is a prodrome and the predrome and there is photophonophobia, always think of migraine despite of the location of the headache. So the location of the headache may vary. It's not a hard and fast rule that the headache should be unilateral and pulsatile. Now in children, what are the differences in migraine? So the differentiation in migraine may be quite difficult in the children because the migraine is a evolving disease. You have to remember that when a migraine starts in very young age, it manifests in a different manner. When it goes into the adulthood, it manifests in a different manner, and in the menopause and in females in menopause and post-menopause, it becomes different. So depending on the age of the patient in which you are seeing the patient, the manifestation of the migraine may also change. For example, in children, younger children, the headache may be bilateral. So unlike unilateral headache, which we say, children may have bilateral headache. 80% of the patient may have bilateral headache, and also the duration of the headache may be very short. So when a child starts to develop migraine, the duration may be 10 minutes, 15 minutes, 2 hours, and then gradually when the child grows old, the duration of the headache also increases. So that is one important feature. And these things you have to be quite aware of, especially pediatricians. The migraine in child can have infantile colic-like presentation. It can present with cyclical vomiting. It can present with abdominal migraine, in which there will be recurrent attack of vomiting and abdominal pain, which gets relieved after vomiting. And then there may be, the child may be very young, they may not complain about a headache, but you can see there is facial pallor, there is photophobia, phonophobia. Child tries to sleep in a dark room when the headache occurs. So that may be indication that the child may be having a migraine. So, but all this diagnosis is a diagnosis of exclusion. You have to rule out serious underlying abdominal causes before you say that it's a cyclical vomiting or a abdominal migraine. Then there is something called as benign paroxysmal vertigo of the childhood, benign paroxysmal torticollis. So these are all migraine equivalents or precursors of migraine in the child, which will evolve into migraine later on. So these things you have to remember whenever you are seeing patients, especially in the pediatric age group. Now, as I already told, the trigeminal nerve nucleus and its distribution. So this gives rise to various type of headache, which can be unilateral, periorbital. Sometimes you may get lacrimation, rhinorrhea, and nasal congestion along with the migraine. So which may give rise to confusion whether it's a sinusitis or a migraine. So sinus symptoms can also occur as a part of the migraine. So unless there are hardcore sinus features, like there is a purulent discharge, there is fever, a severe sinus tenderness, and a CT scan showing sinusitis, you should not say that it is directly sinusitis, because sinus symptoms are quite common in migraine. And involvement of the neck is also very, very common. So a lot of patients will say that the headache is triggered from the neck and then it goes up. So this is again a common symptom of migraine. Now, how will you differentiate sinus pain from sinusitis? So if a patient, you are seeing that there is sinus pain, congestion, etc. So how will you say it's migraine? So if it is a recurrent attack, each attack like lacking there being there for 2 days, and then the patient is totally asymptomatic in between till the next attack, it is likely to be migraine, because sinusitis will not subside on its own within 2 to 3 days, and then the patient will not be totally asymptomatic in between. While in migraine, the patient becomes normal in between. If there is a family history, if there is headache with other symptoms, if there are specific triggers like food and atmosphere and then sunlight, if there are no signs of infection, like there is no purulent cough, there is no fever, and there is no sinus tenderness, then it is likely to be migraine. When will you consider sinusitis? If there is pain in the face, if there is nasal congestion with nasal discharge, increases on cold. So when the patient is having cough, cold, and then there is pain in the sinuses, it's likely to be sinusitis. Fever and purulent discharge, continuous headache, which is not remitting, it is continuously present, does not resolve in 2 to 3 days, it is likely to be sinusitis. One more thing, we should not diagnose sinusitis just based on a plain X-ray. Always do a CT scan of the paranasal sinuses to document sinusitis. Otherwise, just the plain X-rays of the sinuses can be quite misleading. Now, there are few practical points which can help us in diagnostic clues in our OPD, because as I already told, patients do not follow the textbook. So if there is headache which is alternating side, one time headache in this side, other time it is here, likely to be migraine. If a headache with a gradual build-up starts and then gradually builds up over 1 to 2 hours and then becomes very severe, headache which increases on movement, headache with triggers, headache with throbbing vessels. So the patients say that the vessels become thick and there is throbbing sensation. So that is again migraine. If there is vertigo with the headache, it's likely to be vestibular migraine. If the patient complains of acidity, so headache is there and the acidity is there, bloating is there, it's again migraine. Patient is quite irritable during the attack. So patient doesn't want to talk to anyone, wants to sit in a very calm room, doesn't like TV, mobile. So that is again migraine. If the headache increases in pregnancy and the postpartum period, it's again likely to be migraine. Headache which transforms, that means a headache which was episodic in between and then becoming chronic over the time. So that means the episodic migraine is getting converted into chronic migraine. So that again tells that it is likely to be a migraine. If there is a menstrual link, so headache increases during the menstrual period and then subsides after that, it's again likely to be migraine, because migraine has a strong menstruation link. Sometimes there can be exclusive migraine during the menstruation period. So this is called as a menstrual migraine. Headache which reduces on sleep. So lot of work pressure, studies, and then poor sleep, and then headache get triggered, it is likely to be migraine, not sinusitis or any other cause. Headache which reduces on vomiting, very important symptom. Many patients with migraine patient will say that once the headache reaches the peak, the patient vomits and then the headache reduces. So that is classical of migraine. Headache along with memory problem, and headache with cutaneous allodynia. It's a very important symptom. When a migraine patient says that because of the recurrent headache, when they are combing the hair or then touching the scalp or putting the hairband on the scalp, they are developing pain in the scalp. So that means there is cutaneous allodynia. It's a very important symptom of migraine, and this says that the patient has gone for chronic sensitization, or it is going for a chronic migraine. So this requires continuous prophylactic treatment. So this is again an indicator that the patient is developing a migraine like symptom and not any other type of headache. So these are the common practical clues which can help us diagnose migraine better. So you should not miss other causes. So that is again there. You should not overdiagnose migraine. Be careful, and then you should not miss a sinusitis or a tumor or pituitary adenoma, granulomas. Certain conditions can occur along with migraine, like idiopathic intracranial hypertension. Most of the patient, 50% of idiopathic intracranial hypertension will have migraine also. So there may be a transformation in the headache, and then the patient develops a IIH. So that should be kept into mind. Conditions like CADASIL, MELAS, that is mitochondrial encephalopathy, lactic acidosis, and stroke-like things. And this is a cerebral autosomal dominant leukoencephalopathy with infarcts. And this is a meningitis-like picture which can occur with migraine. So all these conditions are more closely linked with migraine, and migraine is a risk factor for this condition. So this also has to be kept into mind. So you should do the imaging wherever you are not sure. So if it is not fitting into the criteria, then definitely you should not miss severe underlying causes and should do the imaging wherever you are in doubt. Now coming to the 3 common differential diagnoses of migraine. So this is migraine, which I've already told, all the features has been discussed. Now coming to tension headache. So this is the second commonest headache which we see in clinical practice. Now, how do we differentiate migraine from tension headache? So now first thing is, tension headache is bilateral. It is a band-like sensation which occurs in the scalp. One important thing is tension headache is featureless headache. So featureless headache means there is no nausea, vomiting, there is no photophonophobia, there is no increase or worsening in physical activity. So these things will tell that it's a tension type of headache. It will be present for longer duration. That is, it can last up to 7 days, tension-like headache. But the patient may be active during the headache also. So this is a mild type of headache which occurs, and patient goes on with the normal day-to-day activities with some discomfort and a headache which is non-throbbing, belt-like or band-like sensation towards the throughout the scalp. So that is tension headache. Now cluster headache. So cluster headache is the third most common headache which we see in our practice. So this is also called as trigeminal autonomic cephalgia, or TAC, TAC. So now what is the important thing? It is trigeminal autonomic cephalgia. Cephalgia means headache. Trigeminal means it's around the trigeminal distribution, mainly around the V1 distribution. So it is mainly periorbital type of pain. And cephalgia means pain, and then autonomic symptoms will be there. So what are the autonomic symptoms? So there may be tearing from the eyes, redness of the eyes, swelling of the eyes, there may be ptosis, and also nasal congestion and nasal discharge. So if we are having a unilateral periorbital pain with nasal congestion, nasal discharge, swelling of the eyelids, Horner's syndrome, and all those things, then it is likely to be cluster headache. Cluster headache, one important thing is, it is a very, very severe type of pain. It is one of the worst headache syndrome. So the pain is severe, excruciating pain. Unlike a migraine patient who may also have a severe pain, migraine patient will try to lie down in a calm and dark room and try to take rest, while a cluster headache patient will be restless, agitated, and will be running around. So that will be one important feature which can help us in differentiating from migraine from cluster. Second is the duration. Migraine lasts from 4 to 72 hours, while the cluster headache will be from 30 minutes to 3 hours. So 3 hours is the upper limit, and the attack may occur during the same time in the every day. So that is called as periodicity. There will be classical periodicity. It will occur in the same time. It may occur during sleep and awaken the patient from sleep. Cluster headache. The duration is short, it is severe pain, and it is abrupt onset and reaches its peak very quickly within 10 to 20 minutes. Unlike migraine, which is gradual onset and increasing. With these features and the autonomic symptoms, you can definitely differentiate cluster headache from that of a migraine. So this is the diagnostic criteria. Again, 5 attacks, 30 to up to 3 hours it can last. There will be a lot of autonomic features, and the patient will be restless and agitated. The attack may occur 1 in alternate days to maximum up to 8 times in a day. So that is the maximum frequency, 8 times in a day, and it may be as less as 1 in a alternate days. So with all these features, you can diagnose cluster headache. The importance is that 2 things are important. One is, if you are having a cluster headache, you should look for secondary causes, because in cluster headache, there may be a lot of secondary causes like pituitary tumors, meningiomas around the trigeminal nerve, which is causing compression and giving rise to the headache. So cluster headache, you have to do the MRI scan. Second thing is the treatment of cluster headache is different from that of migraine. So that is the two important thing which makes it important to differentiate it from migraine. Now, the group of headache which I told is TAC, that is trigeminal autonomic cephalgia. So there are four types of headache which comes in the TAC group. So one is cluster, which is the most common type. And one more important thing about cluster is more common in male patients, while migraine is more common in female patients. So the second common trigeminal autonomic cephalgia is paroxysmal hemicrania, Sankt Suna, and hemicrania continua. So these are the various other causes. Now I'll not go into the detail because it will be very extensive. So here what you can remember is that cluster headache, the duration is maximum up to 3 hours, while for paroxysmal hemicrania, maximum duration is up to 30 minutes. And for Sankt and Suna, it is within seconds and minutes. So you go towards the right, the duration of the attack reduces, but the number of attack increases. So here cluster headache can occur 1 to 8 times. Paroxysmal hemicrania will occur 5 to 50 times, and Sankt and Suna will occur up to 1 to 100 times. So it will be recurrent headache, very short lasting around this area, and there will be conjunctival ingestion, autonomic symptoms. While in cluster, it will be longer duration, less frequency of attack with the symptoms. So with that, you can differentiate whether it is which type of trigeminal autonomic cephalgia. Now, the important thing is that if you are having a symptom suggestive of trigeminal autonomic cephalgia, always work out for secondary causes, because there may be many other causes which may be giving rise to this syndrome. For example, pituitary tumors are notorious to cause this. Meningiomas are not notorious to cause this, dissection and all those things. So definitely you have to do the scan of the brain before you say that the patient is having a trigeminal autonomic cephalgia. Unlike migraine, in which if the duration is long and the attacks are pretty typical, then you need not do a scan of the brain. Now, one important thing I'd like to highlight is medication overuse headache. So this is a very common disorder, very common condition, and it is frequently underdiagnosed. So whenever a patient comes with a very bad headache, daily headache, not responding to medication, always ask the history of medication overuse, because most of the time these patients will be taking a lot of painkillers, which is giving rise to worsening of the headache. So this history has to be taken. So what we call as medication overuse is headache on more than 15 days in a month, lasting for more than 3 months. And if there is use of painkillers for more than 10 days, if the patient is taking complex painkillers like opioids or triptans and all those things, more than 10 days. And if it is simple painkillers like ibuprofen or Voveran, etc., diclofenac, etc., then it should be 15 days per month. So if simple painkillers more than 15 days, complex painkillers more than 10 days per month, if there is an intake, and if the headache is more than 15 days for 3 months, definitely you have to consider medication overuse headache. Why is it important to know this condition? Because unless you stop the overuse of the medication, this headache is not going to respond. So you have to stop gradually or abruptly. There are two ways of stopping the medication. So you have to stop the medication and add on prophylactic medication so to prevent the headache. And also you may have to give a bridge therapy to tide over the initial 5 to 10 days whenever you are reducing the medication overuse headache, because they may be having a rebound headache as soon as you reduce the medications. I will not go into the details of this. These are the other primary headache which can occur. So I already told primary stabbing headache, primary cuff headache, primary exertional headache, primary coital headache, and hypnic headache. So all these are primary headache without any underlying serious intracranial causes. But for these conditions, before diagnosing this, you have to rule out other causes by doing a scan of the brain. So there are definite criteria for all of this. So and there is something called as hypnic headache, which is again a primary headache disorder which occurs after 50 years. The patient goes to sleep, and maybe 2 to 3 hours after the sleep, the patient suddenly wakes up with a headache, and the headache lasts for up to maybe 15 to 30 minutes and gradually subside. It occurs at the same time in the night. So it's called as an alarm clock headache. So this is again a diagnosis of exclusion, because sleep headache, nocturnal awakening from headache is again a red alarm symptom, because we have to rule out an intracranial pathology. So if this patient, if you do the scan and the patient is normal, then you say that this is a hypnic type of headache. So it's called as a hypnic headache, which occurs in the elderly population. Again, it's a diagnosis of exclusion. Now, one more group of headache which you should be aware of is indomethacin responsive headache. Indomethacin has a very crucial role in headache medications, because there are a few headaches uh, which can be exclusively responsive to indomethacin. For example, trigeminal autonomic cephalgias, indomethacin act well. You can remember 3 C's, that is cluster headache, C1, cough headache, coital headache. So these 3 C's are the common headaches which can respond to indomethacin. So it is again diagnostic in value. For example, in a paroxysmal hemicrania headache, if the patient responds to indomethacin, so this is almost diagnostic of the paroxysmal hemicrania continua or chronic hemicrania continua. So this can be a diagnostic test also using indomethacin to treat these headaches. And there is something called as nummular headache. When I was doing my medicine MD, then I had seen a lot of patients who complain of small area of round areas of headache in this particular area, and then the headache lasts for some time, and this will be around a diameter of 1 to 6 centimeters. So I was wondering what it was, but now there is a diagnostic diagnosis called as nummular headache, in which you can have coin-shaped headache which can occur and which can be recurrent in nature. So this is one diagnosis. Again, you have to do the scan of the head to rule out any underlying cause. And if the scan is normal, then you can label it as a nummular headache. So this is again a primary headache disorder. Okay, so now we'll go into the treatment of migraine per se. So migraine is of 2 common type. One is episodic migraine and second is chronic migraine. So chronic migraine means if the headache occurs more than 15 days in a month for 3 months. So that is chronic migraine. Episodic means which occurs less. So most of the migraine which we see is episodic migraine. So what are the conditions which predispose to conversion of an episodic migraine to a chronic migraine? So you have to remember that 3% of the migraine patient will get converted from episodic to chronic migraine every year. So if there are 100 patients of episodic migraine, 3 will be chronic migraine in 1 year. So how will you predict which are the patients who are going to go into chronic migraine? The patients who are having high baseline headache, patient who are taking overuse of the headache, patient who are having psychiatric history, so depression, anxiety and all. So these depressed patients are having more chance of developing chronic migraine. One important thing is high caffeine use, obesity. So obese patients again high risk. Patient with obstructive sleep apnea syndrome or sleep disorder, they are again high risk. So whenever you are seeing a migraine patient with episodic migraine, look for the high risk group: overuse of medication, overuse of coffee, obese patient, depressed patient, anxiety patients, and patients who are having obstructive sleep apnea. So these are the 5 risk factor group which you have to be careful and then treat them properly so that they do not get converted into a chronic migraine. There are non-modifiable risk factors also, like female sex, genetic makeup, history of head injury, low education status, low socioeconomic status, etc., which we cannot do much about. So, but these 5 risk group things you have to be careful and manage them carefully. So chronic migraine, as I've already told, for 15 days for 3 months, and 8 days there should be migraine feature should be there. Now coming to the treatment of migraine. So treatment of migraine can be into 2 main branches. First is the abortive treatment or the acute treatment. Second is the preventive treatment. So abortive treatment, any treatment you have to educate the patient, and the most common drugs which we use in the abortive treatment are simplest drugs like paracetamol or other NSAIDs, and then migraine specific abortive treatment like the triptans or the ergotamines. So these are the 3 group of medications which we use. Whenever the patient is having vomiting and nausea and all, then you can give the pumps, or you can give the injection subcutaneous or the oral disintegrating strips or the oral disintegrating tablets, which can be used if the patient is having vomiting. And pregnancy, paracetamol will be the safest. You have to be careful in the first trimester and also the second and the third trimester when you are using medications or NSAIDs in the pregnancy group. So episodic headache, specific treatment, non-specific treatment. Specific is triptan and ergot. Non-specific is NSAIDs and antiemetics. So these are the 4 groups. So now coming to the NSAIDs. most common is paracetamol, which can be used. Then the three common NSAIDs which can be used is ibuprofen, diclofenac, and naproxen sodium. And aspirin is also sometimes used. So these are the common drugs which can be used. The dosage, I think you are quite familiar with that. The advantage of paracetamol is that it is a less gastric irritation. So it can be used for mild migraine attack. So when the patient has very mild migraine attack, you start with paracetamol. If the attacks are more severe, you can give ibuprofen, diclofenac, or naproxen. Now the important thing is that diclofenac is more potent and rapid onset of action, while naproxen sodium, the importance is that it has slow action but lasts for longer duration. So if you give a single dose, it will prevent further attacks in the next 12 hours to 14 hours. And it has a favorable cardiovascular profile. So heart disease patient, naproxen sodium may be quite beneficial. And ketorolac is another drug which can be used, which I have not used much. So usually I use ibuprofen, diclofenac, and naproxen. Naproxen is what I use in most of the patients, but sometimes some of the patient may not get much benefit. So in those patients, ibuprofen or diclofenac can be used. It can be, I'll show you the dosages. Now coming to the triptans, these are the first line medications which can be used if the attacks are very severe. So if the attacks are very severe, you have used paracetamol, failed, you have used ibuprofen, diclofenac, naproxen sodium, and all of the medications first line have failed. So in this patient, triptans will be the good medication which you can use. There is nothing called as a best triptan because it may vary from patient to patient. Some triptan may work well in one patient, others may work in some other patient. And at least you have to use for 2 to 3 attacks before saying that this triptan is not working. So these are the various triptans which we have: Elmo, Eli, Frova, Naratriptan. Commonly, I have used rizatriptan in patients. Sumatriptan have also been used, and zolmitriptan. The advantage is that rizatriptan is available as an oral wafer form and oral disintegrating tablet. Also, thin wafers are available which can be given under the tongue and which get absorbed immediately. So if the patient is having severe nausea, vomiting, so this can be used. Sumatriptan, the advantage is that it is available as a subcutaneous injection as well as a nasal spray. And for zolmitriptan, the advantage is it is again available as a nasal spray and oral wafer. So these 3 triptans is commonly used in our practice. Now, contraindication for triptan. If you are using triptan, you should be careful because if there is a hemiplegic migraine, if there is a stroke, heart disease, you should be careful. You should not use with other myo-inhibitors because there can be severe reactions with that. Serotonergic syndrome is one rare condition which can occur, especially if you are using with SSRI and SNRI, but it is exceedingly rare in clinical practice. So it's usually not seen. But this should be kept into mind whenever you are using with these medications. And adverse effect, many patients when taking triptan, they will say that they will have sudden sweating, tingling, and feeling of uneasiness which lasts for up to an hour. So this is quite common. This can occur. If it is severe, you should not use triptans. Now, sulfa allergy, you have to be careful because sumatriptan has sulfa moiety, also other triptans. So sulfa-free triptans are zolmitriptan and zolmi and the sumatriptan. So these are the sulfa-free triptans which can be used in case there is sulfa allergy. Now there is one combination of naproxen with sumatriptan. So this is again quite effective because naproxen gives a longer effect and sumatriptan gives the initial effect. So this can be quite usefully used. It can be used, but the thing is that you have to use maximum half to 1 tablet. Do not use more than that because this may cause problems to the patient. Now, what are the advantages of triptans over ergot? Before the rampant use of triptans, ergot were the first line medication, but triptans are having higher receptor sensitivity, good bioavailability. Also, the nausea and vomiting is less. It is well tolerated, and the coronary vasospasm is less in case of triptans. While for the ergot, severe cardiac issues, Raynaud's phenomena, gangrene, and all those things may occur. So, triptans are definitely favored more than the ergot compounds. So this is a summary of the acute treatment. So acetyl, that is paracetamol is there, aspirin, diclofenac, ibuprofen, naproxen. Level A evidence is being given. All the triptans are having level A evidence. Ergot is also having level A, and combinations. These are all quite effective. Now the dosage: sumatriptan nasal spray is there. Sumatriptan tablets are also there, and rizatriptan and zolmitriptan. So these are the various T-half of this medication and the maximum dosages. So you look at this, naproxen sodium can be given up to twice to thrice daily. Ibuprofen can given up to 2400 mg and diclofenac for 150. So that is thrice daily. So this can be given according to the requirement. Now there is a condition called a status migrainosus, which I've already mentioned, in which the patient develops severe headache not responding to the medication. So in that case, you have to give intravenous medication. So that is, in an emergency department, you have to give IV fluids. You have to start with antiemetics. So the medications which can be used in such cases are IV magnesium sulfate. So magnesium sulfate can be used, and you can also give steroids. So steroid dexamethasone or methylprednisolone can be given. So methylprednisolone 200 mg can be given. Anti-epileptics are found to be quite effective, especially sodium valproate and levetiracetam. So these medications can also be helpful in treating the acute migraine attack. So this is one group of medication. I will not be going into detail because we do not use it commonly. It's called as the GPANs. So GPANs like Olcigepant and Telcigepant, etc. has been used. Telcigepant has been removed because of the hepatotoxicity, and Olcigepant is again terminated because of issues. So these are the other medications which can be used both in acute as well as the preventive treatment. Now coming to the preventive treatment, how do we decide regarding the preventive treatment? So what are the criteria? So when should you start preventive treatment? So you have treated the acute attack. Now when should you give preventive or continuous medication for these patients? So if there is significant interference with the routine activity, headache is affecting the activities of daily living and affects the routine activity. If the attack frequency is more than 1 per week or 4 times in a month, if there is increased risk of medication overuse, headache or chronic daily headache, if the acute medications are causing a lot of side effects, are indicated and is having not much effect, then you have to give preventive medication. If the patient prefers not to have a regular migraine and also complicated migraine like hemiplegic migraine, brainstem migraine, prolonged aura with a history of stroke due to migraine, you have to definitely give preventive medication. So that means if there is more than 4 attacks in a month, if there is affecting the quality of life, if the acute medications are ineffective or contraindicated or having severe side effect, for example, a peptic ulcer or cardiac illness, you cannot give acute treatment. So these patients you have to give preventive medications, and also complicated migraine. So what will be the target of preventive medications? So will you think that there will be 100% control of the migraine? No. So you target that there should be reduction in the attack frequency by 15%, 50%, severity and the duration of the attack should also at least reduce by 50%. You expect that the acute medications in case of attack should respond better, and overall the patient functional ability should improve. So this should be the target of the treatment, and this should be made clear to the patient during the first visit itself, because most of the patient may think that the migraine will be totally cured or they may get complete recovery. So that should be clear to them. So these are the things in preventive treatment. You have to time and focus the plan. The treatment, there is no fixed rule. You have to customize according to the patient. Patient education should be there. You have to fix the goal, set the right expectation. You have to tell about the duration of the treatment. One very important thing is lifestyle modification, trigger control. So you have to say that you have to maintain a regular lifestyle. Routine lifestyle should be maintained, waking in the normal time, sleeping in a fixed time, proper meals, proper food, regular exercises, avoiding triggers, avoiding food which is triggering the attacks. So all those things has to be taken into account. And then you have to stratify whether you are going to give a single drug, single medication or a polytherapy, and not the same drug always, not the right drug in the first time. You have to tell the patient that you are starting with a medication. Probably the medication may not control the migraine initially, then you will change over. So because it's a trial and error basis, so you are not having any fixed medications. You may start with a beta blocker, you may start with amitriptyline. So whether the medication is acting in the same manner in all the patients, it's not the same. Some medication may be acting well in some patients. So that has to be told, and you have to tell the patient that it's a trial and error basis. You will try to find out the right drug for the patient and then continue the medication. You have to tell them that you have to follow up the doctor, and then the titration of the medication will be done during the follow-up. And the risk factors, you have to see the comorbidities, you have to see, and then whether you have to combine the medication also, you have to see later on. Now, the patient profile, what you have to see is what all illness the patient is having, whether the patient is having some myofascial pain, whether the patient is having depression, fibromyalgia, what is the headache profile, it's whether it's episodic migraine, whether it's a chronic migraine, whether there is medication overuse, that has to be found out, whether there is a aura, whether there is a vestibular element, all those things has to be taken into account, whether there is any special situation which the patient may have, whether if it's a young female going to get married, then whether there is a chance of pregnancy or not. If the treatment is not working, why is it is failing, whether the patient is not following the lifestyle, whether the medication is not being taken properly, all these things has to be taken into account while taking the things. So patient education is the key. So you have to communicate to the patient, take time, and then properly talk to the patient, because I have seen patients who have been started the right medication, but they have left the follow-up just because the communication has not been done properly. So you have to tell that there is no cure, control 50 to 16% you can control. There is no definite course of the migraine, because the migraine behaves in a different way in different patients. And whether you are going to give a single medication or whether you are going to give a dual medication, that depends upon the type of the migraine. So there is no fixed rule for the patient. And once the patient's headache reduces, the medications will also go down. So that also has to be told to the patient. The comorbidities, the common comorbidities which occur in the migraine patient are mood disorders, neurological conditions like epilepsy, stroke, etc., cardiovascular issues, musculoskeletal problems, and gastrointestinal disorders like irritable bowel syndrome and GERD, which is very common in these patients. Fibromyalgia is also very common. Can you just mute your mic, please? Can you just mute your mic? So this is one way in which you can select the proper drug. Suppose if the patient is having a depression, you give amitriptyline. Avoid beta blockers of flunarizine, which may worsen the depression. If the patient is having insomnia, amitriptyline will be a good drug. If the patient is having bipolar mood disorder with migraine, divalproex sodium or topiramate will be good. If there is a myofascial pain, fibromyalgia, amitriptyline will be good. If there is hypertension or angina, beta blocker will be good. If there is low BP, because propranolol and flunarizine all will cause reduction in the BP. So if there is low BP, divalproex sodium or topiramate will be good. If there is epilepsy with migraine, you will better start topiramate or divalproex sodium, which will help in both the condition. And if there is epilepsy, you should avoid amitriptyline because it may reduce the seizure threshold and precipitate a trigger a seizure. Asthma, you have to ask. Diabetes, you should avoid beta blocker. It may prevent the proper glycemic control and also affect the hypoglycemic awareness. Obesity, you have to use. You should avoid medications like. One important thing is that most of the migraine medications increase the weight. For example, flunarizine, valproate. Flunarizine, valproate will increase the weight. Amitriptyline will also increase the weight. Only beta blocker are weight neutral, as well as topiramate, which may reduce the weight. So obese patient, you can use beta blocker or topiramate and avoid the other medications. So you can titrate the, you can select the medication depending upon the comorbid condition and try to use the minimal medications. So there are various guidelines. So you can level of evidence you can see based on the Canadian and all these guidelines. Propranolol, metoprolol, divalproex sodium and topiramate are level A. Level B is amitriptyline and venlafaxine. Level C is candicertin and all those things which we rarely use. So most commonly the drugs which we use is propranolol, divalproex sodium, topiramate, amitriptyline and flunarizine. So these are the 5 medications which we commonly use, and also sometimes venlafaxine if there is associated depression, anxiety and all those things. And each of this patient, you have to take care of the patient profile, the contraindication, the side effect and the cost and efficacy in every of these patients whenever you are starting the medications. So these are the various contraindications. I will not go into the detail. Beta blocker, you have to think of bradycardia, hypotension, asthma, peripheral vascular occlusive disease, diabetes mellitus, depression. So these things you have to be careful about. Topiramate can cause cognitive issues. So any high professionals who are working in a very highly active situations in which they need very high presence of mind. So you should avoid topiramate because this causes cognitive slowing and all those issues. If there is renal stone, you have to be careful. And if for weight loss it is good, the side effects are paresthesias, tingling, and all those things which can occur. Amitriptyline, it's a very good drug. If there is depression, anxiety, and all those things, you can start using it. But the issues are dry mouth, prostatic symptoms, orthostatic hypotension. So elderly patient, be very careful whenever you are using amitriptyline. Always ask history of glaucoma for topiramate and amitriptyline because it can trigger ankylosing glaucoma. Divalproex sodium is a very good drug, but in young females who are of the childbearing age group, you have to be careful. It can cause PCOD, it can cause weight gain, it can cause hair loss. So in females, young females, it may be not a very good drug. It can worsen the tremor, it can cause hepatic issues, pancreatitis. So all those things you have to keep into mind while starting the medication. Venlafaxine is a good drug if there is associated depression and anxiety. Flunarizine, the common side effects are weight gain is the most common side effect. Low BP is one important side effect. Worsening or depression is one side effect. One very important thing is Parkinsonism. So it can cause tremors and drug-induced Parkinsonism. So be careful when you use in the elderly population. And rest of the medications, not much side effects are there. So the basic principle is start low, increase the dose slowly, adequate trial at an appropriate dose. So you can give the maximum tolerated dose for at least for 4 to 6 weeks before saying that the medication is not effective. So it's not that you every week you change the medication. At least wait for 6 weeks before you say that the medication is not effective. Evaluate the therapy periodically. Look for side effects. So if the patient is on medication, coming on follow-up, you look for the heart rate, you look for the blood pressure, look for tremor, look for the weight, whether there is any side effect which the patient is developing. Assess the comorbidities and coexisting condition and specific concern for pregnancy. So that means the prevention is a dynamic process. So it is not that you start one medicine and they leave the patient like that. You have to follow up the patient, monitor for the toxicity and also the change in the circumstances, any comorbidities which are getting adding on. So it's a dynamic process and you have to follow up the patient regularly and meticulously during the follow-up. So these are the various level of evidence. Suppose if there is migraine and hypertension, propranolol will be the better agent. I've spoken about this. Depression and insomnia, amitriptyline. Women of childbearing age group, avoid valproate as well as topiramate because topiramate is also causing teratogenicity. It can cause cleft palate and all those things. And valproate definitely, you know, it's teratogenic. Obesity, topiramate would be a good drug. And if one drug is insufficient, you start the second preventive agent. And if 2 or more oral drugs you have failed, then you can definitely go for the newer drugs. That is the CGRP receptor blockers as well as the monoclonal antibodies against the CGRP, and also botulinum toxin, which is again available. So these are the few medications which can be started if the first line medications and also the second the preventive medication fails. Now coming to the role of newer agents. So these are called as nutraceuticals. So 3 agents: magnesium and riboflavin and coenzyme Q. So this have been used in the preventive medications and they are relatively safe and also moderately effective. So magnesium is found to be effective in various studies and which is in migraine, and similarly riboflavin 400 mg has been found to be effective, as well as coenzyme Q. So there are various combinations which are available of these 3 which can be used for the treatment of prevention of migraine. So you look at this, the American Academy and the Canadian Society. So they say that coenzyme Q, magnesium and riboflavin, level B evidence for coenzyme Q, level C, and Canadian gives a strong evidence for this. So these are other agents also which can be used in mild migraine in which the other preventive medication is causing side effects. So these are the add-on therapies which are available now. And you should also know that there are a lot of other mechanisms in the migraine. So there should be a holistic approach for treatment of the patient. So that means you can use nutraceuticals, which I've already mentioned, biobehavioral therapy, alternative therapy like yoga, meditation, physical therapy, and all those things may also be quite effective. So the patient should do regular exercises, yoga, and all those things may be compiled together to give a good result to the patient. So botulinum toxin is a FDA approved drug which can be used in chronic migraine. It has to be given as injection in multiple sites and for treatment, and it is found to be equally effective to that of topiramate and amitriptyline. So it is used as a second line agent. Once the oral medications fail, you can definitely go for botulinum toxin. But then the issue is the cost of the therapy and also injectable injections which has to be taken frequently. So to summarize, the layered things will be: first, you start with pharmacological treatment, the normal medications which are available. If there is not much response, you can go for the nutraceuticals like magnesium, coenzyme Q, as well as riboflavin. And then botulinum toxin will be add-on therapy which can be tried along with this. You can add non-pharmacological treatment, physical therapy, behavioral therapy, cognitive behavioral therapy, and all, especially in patients who are having associated anxiety and depression. And later on, if the treatment with these modalities fail, then you can go for anti-CGRP antibodies, the GPANs, and neuromodulation devices, etc., which are also available. The anti-CGRP and GPANs are not widely available in our country, while the neuromodulation like cephalgia is available in our place. So these are the various monoclonal antibodies which are there. I'll not go into the details. These are the 4 antibodies which has been approved by the FDA. Most of them are subcutaneous, while eftilizumab is IV. So this has to be given every month or every 2 months, and it has found to be quite effective. But the only issue is the cost of the therapy and the injectable thing. But overall, compared to taking medications every day and then having the side effect, these medications are found to be quite safe. So probably this is going to be the future of migraine in the next decade. Let us see how it acts when we use it in clinical practice. So this is found to be quite effective. Almost all of the agents have been found to be reducing migraine in more than 50% of the reducing migraine of about 50%. And it should be used according to the European guideline. If you are used 2 medications for at least 2 medications for at least for 2 months, and without much response, you can go for CGRP antibodies. So this is the approved guidelines, which patient you have to select for the CGRP and monoclonal antibody, that is aged more than 18 years. And then you have used for almost 2 months of 2 drugs, including all of this, without much response. And there are scores, the MIDA score, which is used to score the migraine. So if there is a score more than 11, you can go for this treatment. So this can be used in as a second or third line management. Now coming to neuromodulation devices. So these are various devices which are available, which can help in the treatment of the migraine. This has been found to be effective in chronic migraine, and also in acute migraine. Some of the neuromodulation devices are there. For example, this is a transcranial magnetic stimulator which can be applied in the posterior part to reduce the migraine. This is a transcranial stimulator called as cephalgia, which is again the supraorbital nerve stimulator which can be used. There is a vagal nerve stimulator device which is available, and there are various nerve blocks, occipital nerve blocks, greater auricular nerve blocks, etc., which can be used to reduce the migraine attacks. So these are the various neuromodulation which has been effective, and this is quite effective, especially in pregnancy and those conditions, especially when you cannot use the prophylactic medication. So in this case, neuromodulation also is quite safe and effective. So in pregnancy is one scenario which becomes very difficult. So you have to take care of the teratogenicity and the side effects also. So pregnancy, which medication you should not use? So sodium valproate should not be used. Topiramate should not be used. Flunarizine should not be used. The 2 medications which we use for preventive treatment in pregnancy is low dose of beta blocker as well as low dose of amitriptyline is found to be effective. Magnesium, as it is available now, magnesium sulfate can also be effective in the treatment of the chronic migraine. In acute migraine, NSAIDs you should be avoiding during the 1st and the 3rd trimester. While in the 2nd trimester you can use it. Steroids may be used. So that is for the acute treatment of the migraine. Opioids in low doses can be used. Triptans you should you can use in the initial phase, but you should try to avoid triptan. So in the pregnancy, you can either use paracetamol or NSAIDs or steroids if it's a severe migraine. And as prophylaxis, you can use low dose amitriptyline and low dose beta blockers. Definitely avoid sodium valproate and topiramate. And the nutraceuticals, the safety is not very clear. Magnesium, riboflavin, it's not ranked. Amitriptyline class C, as I've already told, can be used. Topiramate and valproate is X, and then topiramate is D. Now coming to the question of when to stop medications. Usually there is no fixed period of stopping the medication. The various studies have found that it's around 6 to 9 months or up to 1 year. You have to continue the medication. And if the headache is well controlled for 6 months, you can gradually taper and stop the medication, counsel the patient properly regarding the problems which may occur. There may be a relapse of the headache, there may be recurrence of the headache, so that all things has to be counseled to the patient. So tension headache, it's almost the same, but amitriptyline is the drug of choice in tension headache. Nortriptyline, venlafaxine, mirtazapam can also be used. And non-pharmacological therapy like cognitive behavioral therapy, psychotherapy, and all those things may be used whenever there is associated depression, anxiety, and all those things. Cluster headache, as I told, the treatment is different from that of migraine. So in the cluster headache, oxygen, high flow oxygen with a non-rebreather mask is very important treatment, and it is one of the drug of choice. It's almost diagnostic. If you give high flow oxygen, almost 100% of the patients with the cluster headache will respond to the high flow oxygen. You can also give triptans and steroids. Steroids may also be given in the cluster headache. Nerve blocks may be quite useful. And in the prevention, verapamil is the drug of choice, and we can also use topiramate and sodium valproate, which can be used. And lithium can also be used in chronic cluster headache. So verapamil, lithium, topiramate are the common drugs which are used in treatment of the cluster headache. So I think this is the last topic, medication overuse headache. So what will we do when you see that a patient is having chronic medication abuse and then headache related to that? There are two mechanisms of treatment of medication overuse headache. One is abrupt stoppage of medication, and second is gradual taper and stoppage. So there are two schools of thought. So ideal thing will be you gradually taper the medication overuse, which is being overused, gradually taper over a period of 3 to 5 days and stop it. During the intervening phase, you have to give a bridge therapy, which can be either a low dose of NSAID or a steroid for 5 to 10 days. And then you can bridge the period so that you can taper the medication during that time and also start preventive medication along with that. Now, the issue is if the patient is on opioids and benzodiazepines, abrupt taper may give rise to withdrawal symptoms. So if there is opioid, then you have to give a clonidine patch for 1 to 2 weeks to prevent the withdrawal, and then you have to taper. So if it's a opioid or benzodiazepine abuse, then you have to taper very gradually because there may be withdrawal symptoms. Rest of the medication you can taper rapidly and stop, and then provide the bridge therapy to reduce. And then you have to counsel the patient and tell them about medication overuse regarding the medications, maximum how much they can use. So ideally they have to keep the medication use that is less than 9 per month. And if it's a simple NSAID, it should be less than 14 days per month they have to use. And you should avoid opioids and other butabitol containing analgesics should be avoided. So I think I'll summarize here. So migraine is a frequently underdiagnosed and undertreated condition. Most of the migraine is mistaken for sinus headache, GI related headache, and refractory error. The treatment has to be individualized and depending upon the headache severity, the type of the migraine, and the patient profile, the comorbidities and other issues, the cost of the therapy as well. Proper rapport and communication is the most important thing which will help in the success of the treatment. And you should also consider non-pharmacological treatment like behavioral therapy, yoga therapy, and other things, as well as nutraceuticals whenever you're treating complex migraines. So I think I'll conclude here. Thank you.